Welcome back to Therapeutics. We'll talk about drug interactions here, and this will set the framework for what you as a clinician will begin to think about with managing patients with drug interactions. You'll see these every day in your practice all day long, and it's important, I think, at least at this juncture early on in the curriculum, to give you the framework to think about these interactions. And don't worry so much in this particular block over the summer about the specific interactions. The ones that are more major, you'll become more familiar with as we cover the content in therapeutics. But most likely in your practice, because virtually everyone is using electronic medical records everywhere, you'll also likely have a drug interaction alert system triggered to those orders. So the focus here is primarily to differentiate the concepts of drug interactions: drug-drug, drug-disease interactions, drug-food interactions, the general understanding of a mechanism of many of the most common interactions, and some initial thought about how clinicians manage those. The general way that many clinicians think about drug interactions is to think about the type of interactions that can happen. And in my mind, the simplest way to differentiate these are to determine, particularly with drug-drug interactions, but also drug-food and drug-lab interactions, whether or not the interaction is a pharmacokinetic-based interaction or a pharmacodynamic-based interaction. And by kinetic, meaning that the presence of one drug may affect the absorption, the distribution, the metabolism, or the elimination, or maybe more than one of those things, with a second drug, or vice versa. And these most often involve the cytochrome P450 enzyme systems, but not always. There are other pharmacokinetic interactions as well. And we'll also, when we talk about the pharmacokinetic interactions related to the enzyme systems, we'll talk about the concepts of induction and inhibition. Also, we think about pharmacodynamic interactions, and here most often it's when two drugs compete for a same receptor. One may be an agonist, one an antagonist, or maybe two are agonist, or one is partial and one is an agonist, something like that. And those are maybe a little less common, but those are often involved in drug-disease interactions, where, for example, as we've already alluded to, giving a beta-2 blocker to a patient with asthma, at least in theory, could precipitate bronchospasm. So that would be an example of a drug-disease interaction based at the receptor or pharmacodynamic. What will happen as you mature in your clinical practice over this didactic year, over your clinical year, and really throughout your clinical career, is that you'll become more adept at how to assess and manage these interactions. You'll get lots of alerts in practice, and most of those are, you kind of say, okay, that's fine, but I'm going to continue with this combination of drugs, and you often can do that safely. But we'll talk a bit about some ideas about how to consider managing them when they happen, and what you might need to do to monitor those. So not only do I think of drug interactions as, is this pharmacokinetic, affecting the level of one drug or both drugs? Is this, or pharmacodynamic? But I also think, is an interaction between one drug and a second drug? There are interactions with drugs and food. Drug and food interactions happen a lot of times, for example, with drugs that are metabolized by cytochrome P450, 3A4, and grapefruit juice, for example. So that can be an interaction that interferes with that. We'll talk more about that when we get to induction and inhibition. But the similar thing can happen with drug-drug interactions, as noted above, using two drugs that compete for the same enzyme system, for example. We also have sometimes that the presence of a drug can trigger some inaccurate interpretation of a lab value. The most classic example of this, I can think of at least, would be that somebody has a poppy seed bagel, but the poppy seeds sort of trigger a positive urine test for opioids. So sometimes the lab tests are interfered with, or interpretation of that test is interfered with by a drug that's on board or something like that, or a food or something like that. There are different ways we think again of interactions, but again, dynamic versus kinetic interactions. And I think I explained that earlier on. Pharmacodynamic interactions where whether it's drug-drug, drug-food, drug-lab, whatever it is, that it interacts at a receptor site. Whereas pharmacokinetic interactions, drug-drug, drug-food, whatever, that one condition or one drug affects one or more pharmacokinetic variables for that second drug or the original drug. Usually, the most common examples are drug metabolism affecting the enzyme systems, but there are drugs that interfere with drug absorption of a second drug. A classic example is the fluoroquinolones like ciprofloxacin or levofloxacin when they're dosed with calcium or iron salts, bind to the iron salt or the calcium salt in the gut, and when they're binding to that, they are not absorbed. And so that's an example of an absorption issue. That's an interaction. The biggest drug distribution issues happen usually around binding to plasma protein, particularly albumin, but there might be others as well. Drug metabolism is the lion's share of drug interactions, and these may be a little more difficult to predict in some cases because we don't necessarily know genetically what that person's capacity is for certain isoenzymes of cytochrome P450. And even if we did have that genetic information, it's hard to quantify that in a clinically meaningful way that would then help a clinician to estimate how to manage that interaction. Now, it might be time in the next decade or so that that genetic information is fine-tuned enough to apply that genetic information regarding drug metabolism to the patient level that would help you predict, maybe with information support or decision support software, artificial intelligence software, to help formulate a risk profile for that patient with that drug or interaction so you could better manage it. But at this point in time, we don't really use that in a widespread kind of way. Drug elimination, there aren't too many examples of this, but a few. There are some drugs, for example, that will affect the tubular reabsorption, for example, in the nephron of some drugs, and that may affect the levels of that one of those drugs involved in the interaction. The probably most common, though, of the interactions involve the cytochrome P450 enzyme systems that usually metabolize drug. And it may metabolize the drug to either a pharmacologically active, a pharmacologically inactive, or maybe even a pharmacologically toxic metabolite. The enzymes that are involved in that, there are many of them. Probably more than half of the common drugs on the market are metabolized by cytochrome P453A4. But the other two more common enzymes involved in drug metabolism are the 2C agents and the 2D6. There are many other isoenzymes as well. Cytochrome P450 1A2, 2A6, 2Es, and there are others, sort of account for a fair number of potential points of drug interactions. When many of us think of drug metabolism, an inhibitor is something that inhibits the function of the enzyme and therefore decreases the enzyme activity, at least for that substrate. A drug may be metabolized by one of these isoenzymes, but may work to inhibit a different isoenzyme or any combination of things. So anything and everything seems to happen sometimes. So it's sometimes difficult to predict. And layer on top of this genetic variation among all these enzymes in different individuals, it becomes a little hard to predict to the extent to which all this might be going on. But classically, I think of an inhibitor as something that competes with the substrate for use of that enzyme, for metabolism via that enzyme. And so the inhibitor may actually being metabolized itself or occupies that enzyme so that the substrate that you're thinking about giving concurrently with this other drug doesn't get metabolized because it doesn't have access to the enzyme to the same degree. It may happen by competing with it, or there may be some nature that an inhibitor inactivates that enzyme in some kind of way. An example is the antifungal fluconazole. Fluconazole, pretty commonly used antifungal agent, and what it does, it affects cytochrome P453A4 activity such that if I give another drug that's also metabolized by this enzyme, the level of the other drug could go up, and sometimes up dramatically. This might be a concern, for example, for a patient who's on a lipid-lowering drug called atorvastatin or Lipitor. Lipitor as a substrate is metabolized by cytochrome P453A4. If my levels in my body get too high of atorvastatin or Lipitor, I pose a risk for rhabdomyolysis and muscle injury breakdown and kidney failure. And that can happen in any patient irrespective of whether we give them an interacting drug. But the chances for that happening are much greater in a patient who is on Lipitor, particularly high-dose Lipitor, and then we start them on this antifungal fluconazole. What can happen is that fluconazole interferes with the way the body would normally metabolize atorvastatin or Lipitor to its inactive metabolite. And therefore, the levels of the Lipitor go up, because the body can't metabolize it because fluconazole is occupying all of that 3A4 activity. And lo and behold, the high levels of the Lipitor accumulate over time, a couple of days, and the patient ends up with muscle breakdown and rhabdomyolysis, a serious complication. So we're kind of aware that we would want to avoid fluconazole and atorvastatin together. If you needed to use fluconazole for an acute fungal issue, we could do that. The simple way we would manage that is we would hold or stop the Lipitor for a week or so. And since the goals of therapy for Lipitor are preventing some long-term future 10-year, 20-year cardiovascular risk, stopping the atorvastatin and Lipitor for a few days won't have a big negative complication for a patient. And by stopping it, we're going to avoid this potential interaction that could be serious. So it doesn't mean that you can't start them on fluconazole when they're on Lipitor. It just means you need to be aware of what could happen and whether or not it makes sense to hold one of the other drug, the substrate drug in this case, of Lipitor. Okay? Inhibitors themselves they can complex to multiple drugs. There can be forms of, some drugs that link on to some subsets of cytochrome P453A4 and not others. But typically, inhibiting action happens pretty quickly within hours to days of starting the combination drug. And the onset of what's going to happen and how it accumulates is also affected by the pharmacokinetics of each of the drugs. What's the half-life of each drug? The time course of this interaction in part is related to the time course of normal action of each of the drugs involved. One way to think about pre-inhibition is if you've ever been in a toll booth, let's think about this particularly before E-ZPass were available, or you're on the Mass Turnpike, or you're on whatever kind of setting you're going through toll booths. With our inhibition, there's, maybe most of or 60% or 70% of the lanes are open and traffic doesn't back up because you've got lots of access. You're not saturating that toll booth process. Similarly, you're not saturating or blunting the ability of a drug to get metabolized. In a situation where inhibition is happening, maybe the enzyme is affected by the inhibiting interacting drug, in this case fluconazole, such that the available enzymes for drug metabolism for the atorvastatin, the substrate, are much less. And what happens is things back up. So you could imagine, for example, if all the lanes on the highway for E-ZPass were closed or blocked or not functioning and only one lane, manual lane, was open where they had to take your money by cash, you could well imagine that it's pretty easy to see a traffic jam happening. And when inhibition happens here, what happens is the substrate drug levels go up, sometimes dramatically, and if that's a narrow therapeutic index drug or a drug where those higher levels are associated with some problem, then hence you worry about that being an issue. In a sense, the opposite of inhibition is induction. This happens a little less frequently, but it definitely happens with some drugs. Chronic exposure, or even moderately chronic exposure for a couple of days or weeks of certain medications, results in the body adapting to that and actually producing more enzymes to metabolize it. And so what you'll see is actually more enzyme function happening when you add this drug on board. And what then happens is the blood levels, the levels of any other drug that's metabolized by that enzyme, goes down. This is usually dose dependent. It can sometimes be additive. Induction can also be very specific for the three-dimensional configuration of the drug, what we call stereoselective. And we haven't really talked about the concept of racemic drugs, but racemic drugs are where 50% of the drug is in a right-handed three-dimensional configuration and 50% is a mirror image in a left-handed configuration. And I can hopefully talk more about this in class when we're in class and sort of flush this issue out. But for the most part, just keep in mind, if you know a drug that's three-dimensional in chemical structure, it may have the same number of atoms making that molecule, and the configuration may be identical, except that in the three-dimensional field, one looks like a mirror image of the other. And one of those mirror images may be more specific, not only for binding to receptors, but also for being involved in these drug interactions. So an example, an older drug we don't use much is quinidine, but quinidine is metabolized by 3A4, but it's an inhibitor of 2D6, so it kind of makes it problematic. Well, if I give drugs that are potent enzyme inducers like rifampin or phenobarbital, those drugs, when I add them, can increase the metabolism of any other drugs that are metabolized by those enzymes. So, for example, I'm really concerned when I start somebody on TB drugs, including rifampin, particularly if they're on hormonal contraception like a birth control pill. Why? Because the birth control pill is metabolized, the estrogen is metabolized by these cytochrome P450 enzymes. And if I start rifampin revs up the body's ability to metabolize via these enzymes. Lo and behold, the hormonal contraceptive levels go down because there's more enzymes to metabolize the estrogen. And therefore, the woman could become pregnant. That could be a problem if the woman is getting rifampin because A, the woman intended not to become pregnant, and B, rifampin, if they're on rifampin, maybe they've got tuberculosis, and that's another risk factor for developing fetus. Similarly, with the antiepileptic drugs, older drug phenobar, but this is true for other antiepileptic drugs that we commonly use, like carbamazepine or Tegretol or phenytoin. There's other ones we'll talk about in the neuro block. These drugs, many of the antiepileptic drugs, are also sort of classic enzyme inducers. They rev up these enzymes to metabolize other drugs. Well, I'm concerned about starting many of these antiepileptic drugs in a woman on contraception, hormonal contraception, like birth control pill, because, again, starting the antiepileptic drug may increase the metabolism of the estrogen, leading to the risk for pregnancy. And then, in this case, what makes it even more problematic is that the woman may have been on the birth control because she has a seizure history, and if she were to have a seizure while she's pregnant, that poses a real risk for fetal development and the risk of a pregnancy. On top of that, many of the antiepileptic drugs themselves are also teratogenic, posing a risk for a problem with birth defects. And so you can see that giving anti-seizure drugs with a woman who's on hormonal contraception poses sort of multiple domino effects that you have to kind of think about. One is that the anti-epileptic drug may sort of increase the metabolism of the estrogen, so the woman could become pregnant. And then the woman become pregnant with a condition, seizures, that's problematic, and with drug therapy that poses a risk for teratogenicity, the anti-epileptic drugs themselves. Okay. So pre-induction levels may be adequate, but with induction, we have more enzymes to metabolize the drug levels may become subtherapeutic. Okay, so if you kind of have an idea of this and kind of a framework to think about it, then that gives you an idea of what can happen. What's difficult to know is the degree to which any of this is going to happen in an individual patient, particularly without knowing their genetic information, and even if you did know that genetic information, which we don't routinely use in practice every day yet, even if you had that, it's hard to sort of translate that into, okay, how much of an impact is it going to have? And that even if we had that genetic information, probably difficult in how to manage it. So let's sort of end this sort of session, and keep in mind all of this is intended to be sort of introductory theme-based content, even though I use a lot of examples, and you'll see on the next few slides many examples. It's not our intent to have you sort of know these yet. Over time, many of these interactions will become more commonplace for you for drugs that we commonly use or think about in practice. But at this juncture, I want you to kind of look at some examples of the kind of isoenzymes involved, the substrates, the inhibitors, and the inducers that are more commonly seen in practice. So let's first start with the cytochrome P450 enzyme 1A2. The first left-hand column. These are some commonly used drugs or substances that get metabolized by cytochrome P450 1A2. Caffeine and theophylline are classic examples. Clozapine, which is an antipsychotic that is sort of a last resort antipsychotic because of other side effects, gets metabolized by it. And so is one of these stereoisomers of warfarin or Coumadin, the anticoagulant. So the body will clear or metabolize caffeine, theophylline, clozaril, warfarin into usually inactive metabolites, or some may be active and some inactive metabolites by cytochrome P450 1A2. If somebody's on, let's say, caffeine, I'll keep it simple. Okay, we have caffeine in some cough and headache products for headache, but somebody's like me is a coffee aficionado, drinks a lot of coffee. That's me. Okay. Well, if I also start them on an inhibitor of this enzyme, anything in the center column, particularly ciprofloxacin, some other drugs listed here as well, I may see my caffeine levels go up dramatically. And in fact, when ciprofloxacin, the antibiotic, the fluoroquinolone antibiotic, first came to market, there were actually a fair number of seizures, agitation, insomnia as a commonly observed side effect when patients started on Cipro. And it's come to be sort of observed over the last couple of decades that it may not be the Cipro that's doing that. It may be that Cipro affects the clearance of caffeine. Caffeine levels go up, and so people get more wired, more agitated, and theophylline and caffeine in very high levels can actually lower seizure threshold for somebody who's predisposed to seizures. So here's an example. So how would you manage that interaction? Well, the simple thing is you need to use ciprofloxacin. The management strategy would be ask the patient to hold off on caffeine for a bit. While they're on Cipro, cut your caffeine intake by at least half. And that's the way simply to manage it, but to be aware of it. Theophylline, similar to caffeine, thankfully we don't use much, but we often have to cut the theophylline dose if we're starting somebody on a quinolone antibiotic like ciprofloxacin. We do that. On the far right corner are things that induce the metabolism of the substrate. These are things that make those substrates. You need more of them to get the same effect. And the classic example is cigarette smoking. Cigarette smoking actually induces 1A2 activity. And the issue in practice, the big issue in practice, is going to be, that can cigarette smoking affect the metabolism of the drugs you're on, and therefore you need more drug. With theophylline, for asthma COPD, yes, you'll need more theophylline because you clear it more quickly. Now, you might stop and think, wait a minute. Why is a person with asthma or COPD smoking in the first place? Because that makes their asthma or COPD worse. So that's one example, but it also affects the interaction itself. Maybe you've also had the observation that people who smoke in general often drink more coffee than people who don't smoke. And there might be at least a basis for that in what we see for the basic interaction in cigarette smoking induces activity of some of these enzymes, and particularly P450-1A2, and that caffeine is a substrate of that. Okay, hopefully you're kind of getting the gist of this. Another isoenzyme is 2C9. 2C9, there are a lot of drugs that metabolize it. Here, the more important isomer of Coumadin or warfarin, the S isomer, the form, the 50% of what we give that's in three-dimensional structure of warfarin, is affected or metabolized by 2C19. So if someone didn't have much 2C9, if people didn't have much 2C9 activity, then in fact what you would see is a concern for variable warfarin response, meaning a little warfarin would go a long way because they're not able to metabolize it. Genetically, if somebody has a lot of 2C9 activity, they may need more warfarin to achieve the same effect. But an additional thing happens is we start somebody on one of the inhibitors in the central column here, the effect of their anticoagulation goes through the roof for some patients. You start them on amiodarone, and their degree of anticoagulation is so significant they bleed. That might be true when we start antibiotics like Bactrim or cotrimoxazole or metronidazole flagyl. Also happens with fluconazole, kind of as we alluded to earlier on. So we need to be careful for that interaction. And then we sometimes, by giving inhibitors like rifampin or barbiturates, we may actually see the warfarin levels go down and a patient gets subtherapeutic and risk for clotting. And we may need to increase the warfarin dose accordingly. So these are sort of common-based interactions you'll see in practice. Let's go on to the isoenzyme 2C19. Yet, sort of more examples here. And I think the big clinical issue we've seen in the last 4 or 5 years that involves here is on the substrate side of things, clopidogrel, the antiplatelet. Clopidogrel, a brand name is Plavix. Plavix is chemically inactive, but it gets converted to an active antiplatelet. And this antiplatelet is critical for use in patients at risk for clots, particularly for patients who have a stent placed for coronary artery disease. Because in the first year that they have that stent placed, they're at pretty high risk for a reocclusion of that vessel, a reblockage of that vessel based on a clot forming. And so giving an effective dose of an antiplatelet is absolutely critical to prevent that clot from forming. About 3% of the population don't have a lot of cytochrome P450-2C19 on board. And so we get worried that those individuals just alone may not respond to clopidogrel. And so some tertiary care cardiovascular centers around the country that you do stent placement may actually consider doing genetic testing on a patient to see whether or not they can actually metabolize clopidogrel to its active compound. And if they can't, they'd consider using a different antiplatelet. Well, more than 3% of patients in the populations have at least some degree of inhibition of ability, don't have a lot of this cytochrome P450-2C19 genetically. And for those folks who don't have too much of it, when they start on a proton pump inhibitor like Prilosec or omeprazole, they actually inhibit further metabolism of clopidogrel to its active component. And it's very common to have somebody on a proton pump inhibitor, which is used for acid reflux and for stomach bleeding, for a patient on an antiplatelet drug who's at higher risk for stomach bleeding. And so this is kind of a mini perfect storm kind of interaction. And so the bottom line is that for patients for whom you're starting them on clopidogrel, Plavix, as an antiplatelet, when you have a compelling reason that's important not to have a clot, UA may want to just genetically determine whether or not what's their risk for not being able to metabolize it because they don't have enough of this 2C19, or are they at risk if we started a proton pump inhibitor like omeprazole on board. So there's an example that is actually clinically important. We'll come back and talk about this specific interaction in cardiovascular medicine, particularly in antithrombotics, later on in the year. The cytochrome P450 enzyme 2E1, less commonly used, but here are some examples of substrates and inhibitors. 2D6, a pretty common enzyme where there's a lot of substrates and a fair number of inhibitors and inducers as well. Probably the one that comes to mind here around 2D6 is codeine. And codeine is an older opioid that's chemically converted to morphine. For patients who have little 2D6 or a lot of 2D6, the degree to which they convert codeine to morphine will vary. And then adding or layering on these inhibitors and maybe an inducer, but inhibitors further affects the ability of codeine to be converted to morphine. And so the bottom line is that we'll see is some variation in patients responding to codeine in the first place, whether or not we add an interacting drug or not, based on how much of this 2D6 they have. And then when we add an inhibitor on board, gee, all the more risk for that to happen. This just baseline issue before we even add interacting drug, the pharmacologic variability and metabolism of codeine to morphine via 2D6 is really problematic because codeine converted to morphine are narrow therapeutic index drugs. And since there's genetic variability among who can metabolize it to morphine or not, it's one more variable for a risky drug. The American Academy of Pediatrics over the last decade has pretty much recommended not using codeine in any children at all because it's hard to predict who does and doesn't have in 2D6. And for those who have a lot of 2D6, they may be metabolizing codeine to morphine extensively and having respiratory arrest issues that's been reported or excessive morphine effect. Those who don't metabolize via 2D6 just get codeine and no morphine and probably don't have adequate analgesic response. So here's an example of a drug that is metabolized by one of these enzymes that has potential for both interactions, but even alone, genetic variability renders this narrow therapeutic index drug sort of what I guess I'd consider an old school drug that clinicians really don't use much anymore because we can just give morphine or we can give something else that doesn't have to play around with this patient variability in a drug that's a narrow therapeutic index drug. Probably of all the drugs you're going to use that are metabolized by the isoenzymes, 3A4 is the sort of major one because this is just a partial list. There are many, many drugs that are substrates of 3A4. There are a good number of inhibitors and there are a good number of inducers. And so anybody who's on any drug that's either metabolized by 3A4, inhibits 3A4, or induces 3A4, when you add any other drug that falls in this mix, by its very nature, you can expect an interaction. And those interactions can sometimes be problematic. And so for any of these substrates and many, many more, this is a partial list, and or starting any of these inhibitors or inducers renders this really a sort of a possibility for problems. So we'll talk more in the clinical year about managing that, but you're going to often find that you're going to enter an order for either one of these substrates, inhibitors, or inducers in a patient's record where they're already on another drug somewhere on this page or another drug that is either a substrate of, inhibitor of, or inducer of 3A4. You're going to get a warning flag, but they're usually going to give you also information about what the mechanism of that is, how likely it is to happen, and sometimes within that alert, they'll give you some recommendations for how you might consider managing it. So, and managing often isn't that you avoid entirely, although some interactions you would avoid it entirely. Sometimes the management is I need to monitor response to one of these drugs more or less than I normally would, usually more, or I need to be aware of any other kind of changes that may happen. Okay, that's it.